Good morning, good evening, good afternoon, wherever you are watching in the world. My name is Robert Yates. I'm the Executive Director of the Centre for Universal Health at Chatham House. I'm not actually speaking to you from Chatham House today, unfortunately. I'm speaking to you from a farmhouse in the middle of Tuscany in Italy. So unfortunately, my bandwidth is not too strong. So I think I'm going to be just switching my video off to improve the audio, but just to assure you that I am here and delighted to be chairing today's session. Yes, my name is Robert Yates, and I am head of the Centre for Universal Health at Chatham House, and we are delighted to be having this second event of this series looking at the impact of the COVID-19 crisis on particular services and population groups. The first of our sessions we had 2 weeks ago, we were looking at the impact on elderly people. And today we are very much looking at the impact on cancer services. So I'm just sort of checking with my colleagues that you're still hearing me okay. Can I just have sort of confirmation that you're still hearing me okay? That's excellent. So today we have a very distinguished panel of representing 3 different groups, I would say, looking at cancer services. One from the civil society and an umbrella organization looking at cancer control worldwide, and that's Princess Dina of Jordan, who is the president of the Union for International Cancer Control. We're delighted to have you with us today, Princess Dina. Second, we have the industry perspective. So we have Philip Drouet, who is the Senior Vice President of Oncology, Global Marketing and Market Access for Merck Sharp and Dohme. Third, we have Andre Ilbaoui, who is giving us the perspective of the World Health Organization. He's a medical officer in the Cancer Control Department at the World Health Organization. And they're going to be giving us some introductory remarks in a few moments, but we're very keen that today's dialogue is very much a dialogue and a participative event. And we very much want you, the audience, to join us and ask questions of our distinguished panel. And we'll have this opportunity in about sort of 15-20 minutes for you to ask questions. But if you want to even start asking questions now, if you can do this in the Q&A box. So if you go to Q&A, ask your question and maybe direct it to one of the panelists. And if you like, that you can come on air to join us. We'll be able to promote you to a panelist and you'll be able to broadcast your question to the world. So we would love you to do that. And if you'd like to indicate, if you'd like to do that. Obviously, we are on the record today. In fact, we're being recorded, so we're not following the famous Chatham House rule. This is a very open dialogue that we're keen to discuss with you. So without any further ado, I'd like to bring in my panelists, please. And first of all, bring in Princess Dina from Jordan. You are a great global champion for cancer control and cancer services all over the world. What's your perspective on how COVID-19 has been impacting on cancer services and you know, what we should be doing to ensure that cancer care isn't being neglected in the crisis? Princess Dina.
Thank you so much, Professor Robert, and all the panelists, and hello to all the viewers out there. We all know that since the COVID-19 pandemic, one of the first victims of this pandemic have been the cancer patients. There have been so much disruption for cancer services that has impacted a lot on the cancer community. I actually called our medical director at the King Hussein Cancer Center in Jordan, and I just wanted to see how much of what we've read, you know, on the ground from many people in our community, and also what we've learned from our members from UICC. And I said, Dr. Asem, you know, please tell me, what happened, what happened with the cancer services at our center. And he literally detailed line by line all the items that we've been hearing about. There have been postponement of elective surgery, delayed in treatment, stoppage of early detection services. There have been palliative care has been on the back burner, and so on and so forth. So the cancer community, which really has experienced the double burden of the pandemic, one in the fact that they are the most likely to get it due to low immunity, and also to have potentially not a good outcome from the pandemic if the virus, if they do get it. And at the same time, the disruption of services for a disease, may I remind everyone, that actually kills. Cancer is a matter of life and death. If you don't fight the cancer, cancer waits for no one. It will continue its deadly work. And if we don't have the services that we need to have, radiology, surgery, chemotherapy, etc., you actually don't have a chance. So this has been a big issue. And in fact, the World Health Organization said that about 41%, it was reported, of countries that have disrupted cancer services, and actually it even reached to 54% at its peak. This is totally unacceptable for cancer patients to be having, for actually the medical community having to in a way implement a Sophie's choice approach to cancer patients. Do we treat a cancer patient, or do we treat a coronavirus patient, etc.? And what's really, I would say, apart from that, and of course the economic impact on the cancer community that they are facing now, all the NGOs, that in many countries, in low middle income countries, it's actually the NGOs who are holding the fort in cancer care. Same here in Jordan, the King Hussein Cancer Foundation and Center is an NGO. They will be facing economic downturn, fundraising challenges, etc. So that's another issue. But I would say the biggest issue for me is also the frustration, I would say, that we as a global health community, and you yourself, Robert, Chatham House, you are leading the call for universal health coverage, is, the virus has only, at tragic cost, has merely exposed all the fault lines in our health systems and in our communities. It has unmasked so many uncomfortable truths. In a way, we say the coronavirus has ironically called for us to put masks to avoid it, but it has actually unmasked so many uncomfortable truths, many of which we as the global community, health community, have been calling for so long. It's really maddening. We've always been saying, stop the divisiveness between diseases, build a patient-centered health system. We've always been saying that, health is not just a health issue, it's an economic issue, it's a political issue. You've been saying that all along, Rob, as well. It is a political issue, and we've been saying that all along, and we've seen now what's been happening with politicians actually affecting the responses negatively or positively to the coronavirus pandemic and so on. We've been saying all of that, and now the coronavirus at tragic cost. Now we start talking about medical rationing. I've heard that term. It's like a post-World War II kind of term. Medical rationing, like you said, the old people have been affected. They have had bias against them. There are racial bias in terms of treatment. All of these things that the coronavirus unearthed. And we as a cancer community, certainly, we're fed up. As an NCD community, we are fed up to always be, like in the beginning of the coronavirus, we've had to quickly realign to get support. We had to realign our messaging to link ourselves to the coronavirus, as if we needed to convince people that 9.6 million people who die every year, needs convincing, that we have to align ourselves to the sexy new subject, which is the coronavirus, which of course is a very serious pandemic nonetheless, but the NCDs and cancer is also a very serious pandemic, albeit it's a slow one. So, we as UICC, of course, we had to, first of all, look into our own organization and to, quickly move fast to cut costs, to make sure we don't lose staff, and of course, most importantly, to direct our mission or repurpose our mission to actually serve our cancer community all over the world. We've got more than 1,200 members all over the world from 177 countries. We needed to support them, unite them, show them that they're not alone. And to do so, we have done member dialogues to really offer peer support, practical support, connect everybody together very quickly, because as you know, everybody's taking on dealing with the situation day by day. We've also done training and capacity building in terms of leadership, organizational management, fundraising in these times, practical solutions within the actual technical cancer community of how they can support their cancer patients through technology and otherwise. And we have also, made sure that we continue voicing the voice of cancer patients loud and clear to the international community that, look, cancer patients and NCD patients have to have the right for treatment. This is not a choice. This is not a luxury. We are there, 9.6 million people who die every year. They deserve to have treatment. And if it's planned properly and had countries heeded, the call for universal health coverage like they did post World War II, some countries actually, in fact, if I may divert a little bit, a lot of people think that universal health coverage is for rich countries. On the contrary, as somebody said, if you want to embark on universal health coverage, it's if you are a poor country, because that's where, if you do it properly, you actually look into the inefficiencies, you actually look in innovative ways, efficient ways, transformational ways of delivering service to the patient, not on the basis of diseases and so on. So we have an opportunity in the same manner as after post-World War II. That's when countries like England, Japan, and others actually embarked on universal health care coverage. That is the time when they looked into it. I really feel very hopeful that now that the health focus has been on the agenda and people have seen that now the new wars is not at the, from the end of a pistol or a barrel, it's health issues that is the new kind of wars. And we have to rethink and reimagine our health systems to actually make sure that no one is left behind, not the old people, not the refugees and other vulnerable groups, and not to keep pitting one disease over another, because we can do it all. And we've seen how much political will is able to make things happen when they want to, and they can't find the money when they want to.
Great.
So these are my 2 cents on the matter. I leave it for questions and answers.
Super, super. Thank you very much indeed, Princess Dina. And I like this, what you were saying about the virus has unmasked failings in health systems all over the world. And we see this in Europe. I'm in Italy at the moment, and we've seen it happen in the UK as well. So it's all countries. And I think we do need to be very sort of forward looking, sort of about how we make sure that universal health reforms do sort of address cancer services going forward. If I can maybe sort of turn to Philippe now. Philippe, we're extremely grateful to Merck Sharp and Dohme, I should say, for sponsoring this series and giving us this opportunity to raise these very, very important issues. But looking at the industry as a whole, and not maybe just the pharmaceutical industry, but the private sector as a whole, What do you think is sort of the role of the private sector in ensuring that the cancer control is given adequate attention during the COVID-19 crisis?
Yeah, Rob, thank you. Thanks so much also for the opportunity to join this panel with Princess Dina and with Andre. So Rob, you're right. There's no doubt that COVID-19 is an immediate threat to the entire population, and also threatens already vulnerable patients with cancer and other non-communicable diseases, as was mentioned by Princess Dina. So our first thought is that really governments, industry, and global institutions must work together to tackle the crisis. And our immediate priority must be the prevention and treatment of COVID-19. At my company, MSD, we are contributing to this worldwide effort. First, through the development of 2 COVID-19 vaccines and research on a new antivirus treatment. And secondly, by working around the clock to ensure that our MSD medicines continue to be available to patients who need them, despite some of the logistical challenges that are presented by the pandemic. But listening to Princess Dina, it reminded me of some harsh realities we're facing now in countries around the world, as COVID-19 is having a devastating indirect impact on cancer patients. So in over 80 countries around the world, cancer screening programs have been canceled. Cancer diagnoses have fallen dramatically. For example, in countries like the Netherlands, where new patient diagnoses fell by a quarter in the month of April. And in the UK, the pandemic could lead to up to 18,000 more cancer deaths in the coming year. So to your question, Rob, what can industry do to help cancer patients during the pandemic and beyond? Well, at MSD, during the last few months, we've taken 3 important actions, which I think serve as an illustration of what can be done. First, we've continued working closely with governments and with healthcare systems to bring forward breakthrough cancer therapies that have the potential to extend and improve the life of cancer patients worldwide. We've seen great progress in cancer treatment in recent years, and I think we simply can't afford to lose this momentum during the pandemic. Secondly, at MSD, we've continued to work tirelessly to ensure that all patients who are enrolled in clinical studies continue to get their medication despite the logistical challenges presented by the pandemic. So our philosophy has been no patient left behind. And thirdly, we've worked to secure regulatory approval for more convenient dosing schedules for our medicines, which can help reduce the frequency of visits for hospital-based infusions, which could be important for cancer patients who are more vulnerable to exposure to COVID-19. Now, what additional actions can industry take for a longer-term impact? In countries where cancer care infrastructure does exist to support the administration of innovative therapies, MSD is collaborating with government agencies to continue to accelerate regulatory and reimbursement timelines, and has established patient access programs aimed at addressing out-of-pocket costs in countries where those are helpful. In developing countries where there are barriers to access, including a lack of infrastructure needed for the safe administration of complex therapies, MSD is helping to lay the groundwork necessary to improve cancer health systems, including through our support of the City Cancer Challenge. So what is the way forward? The COVID-19 pandemic has brought the devastating impact of an emerging disease into clear view. Where responses to the pandemic have been well thought out and collaborative, outcomes for everyone have improved, which holds lessons for other diseases. The pandemic underscores the need for our company, MSD, and our industry to continue to invest in research for the greatest health threats, be it for COVID-19 or cancer. There's no doubt that organizations like the WHO and UICC must continue to play a critical role in knowledge sharing and global mobilization. It's also important that governments and payers continue to give timely access to treatment for cancer patients. This is particularly important at this moment, as governments are under intense pressure to allocate limited resources to the most appropriate health investments. In conclusion, it's clear to me that we must continue to act together with urgency to turn the tide on cancer worldwide. Thanks, Rob. Back to you.
Great. Thank you, Philippe. And I think you raised some very important points there, which I'm sure we're going to be discussing with the audience in a while. You know, the very difficult decisions that countries have to make at the moment in terms of, you know, how much they spend on health and health services and how they allocate across sort of different services. And we've been sort of discussing, I think, things like palliative care. You mentioned that Princess Dina. You know, also screening services. I think people are making assumptions about, you know, just sort of treatment services, but whole swathes of screening services being curtailed at the moment. And some really shocking figures you gave us there, Philippe. So if I could maybe sort of turn to Andre now, and maybe just before I do that, to remind the audience of your opportunity. I'm glad to see questions are coming in. We'd like to see more questions to our panel, and let's say that we'll be able to bring you on live if you'd like to do that. So if you'd just like to pop your questions in the Q&A and maybe indicate if you'd like to come on air, and you'll get a chance to speak in a moment. But if I could turn to Andre now at the World Health Organization, which has been championing universal health coverage. We hear Tedros saying that universal health coverage and health security are the sides of the same coin, so very much relating these issues. What do you feel at the World Health Organization are the priorities for ensuring that cancer services aren't neglected in the midst of the global pandemic, and also, more importantly, you accelerate progress towards universal cancer services coming out of this crisis? Andre.
Thanks, Rob. May I begin also by sharing in the privilege of this platform with you, with dear friend Princess Dina, and with Philippe. It's truly a privilege for us at WHO to be able to speak in this unique and important webinar. And our thanks to also MSD for bringing people together for this important discussion. Brief warm greeting also to the many participants that I see are joining from around the world. So this is a very important question. I think Princess Dina and Philippe have led into the discussion quite well. To understand the context of COVID-19, the best starting point is to understand what exactly have we unmasked, as Princess Dina has said. What has this pandemic exposed? Well, first, let's continue to realize that cancer is on the agenda. We know that the cancer burden remains high. 1 in 2 men in high-income countries, 1 in 3 women in high-income countries will develop cancer in their lifetime, and that will not change. Every family will be impacted by cancer. Now, what has COVID done? Out of interest, we did an informal Google search to see what is the most common accompanying search term as it pertains to diseases with COVID. And in fact, cancer was linked to 1 in 10 COVID-19 searches. That is absolutely remarkable. The challenge was when we looked at what are the composition of these articles, what is the composition of these webhits, many of them are talking about fear. COVID is going to end the life of all cancer patients and we are failing. That's a starting point, but that's not the constructive response that we as a community need to formulate. So what is it that we're asking, and how can we structure that in our dialogue with governments, in our dialogue with stakeholders, and of course with the cancer community? The cancer agenda is alive, but how do we mobilize this public interest into action? Second, unmasking, and I really like the analogy. Now, as we have said, health systems are fragile. High-income countries, low-income countries, it is absolutely true. We have seen it, even those with the strongest capacities. Most concerningly, the vulnerable populations, as we've known, are such as those lower socioeconomic backgrounds, the elderly. They are both at higher risk of COVID and of cancer-associated deaths. So how do we orient this response around UHC, around equity, and around value for money? We are doing some modeling to understand what can we do, what are some of the mitigation strategies to consider, but only as a starting point, such as the studies that Philippe has mentioned. If we look back at what happened with the economic downturn of 2008, we saw hundreds of thousands or tens of thousands of excess deaths from cancer. If that was for a 1-year economic downturn, can we imagine what will happen now when you combine the effect of the pandemic with the global disruption in all sectors? So how do we then respond with mitigation strategies that are evidence-based and coherent? Determine what are the right investments. A third point about unmasking that I think is also quite relevant to reflect on as a group. The global health architecture is fragile. All actors are at risk. We have a perception now that, of course, communities are feeling it. NGOs are feeling it, as Princess Dina very honestly displayed for us, to think about what can UICC do. And that vision is what we applaud in UICC and in others, because things will need to change for NGOs, for the private sector, as Philippe is mentioning. And to make matters worse, there is an abundance of misinformation that is pushing money away from normative agencies with reputation, and towards places for which we do not know what their mandate, what their role, and what their functions are. So how can we come together in the global community and support the architecture that we know is oriented to support member states and to support the communities in need? And finally, what are the mitigation strategies? So we can talk about the right investments. We have been talking about them for many years. It starts with UHC, yes, but how can we be a bit more concrete? And in fact, as Princess Dina pointed out, World War II, previous economic downturns have been good case studies. We are starting to see, so within WHO, we look at emergency response and preparedness plans from countries, and many of them do include NCDs, including cancer. What are they doing that we can learn from? What type of accelerated programmatic change can we consider? Is it a telemedicine? Is it shortened or altered treatment plans, as Philippe was rightly pointing out? These are our opportunities to say, these are the investments, here's the evidence to support acceleration and progress. Because without this innovation and without this opportunity for innovation, we're going to be back at square one saying, UHC, please remember us in cancer. So what are the messages then we propose as we work with governments in the cancer and COVID-19 context? First is to invest in the fundamentals. So of course, there's always a need to do a situational analysis to establish priorities, but we know that there are fundamentals, and this pandemic has shown it to us. We start with UHC, but besides talking about UHC, which often is about financing, can we also talk about UHC in the context of equity, value for money, service structure, so that people can receive care at the places closest to their home in the people-centered way that Princess Dina has reflected on? And within the system, what is really our weakest link? Let's talk about the workforce. This pandemic has also shown the vulnerabilities of a weak workforce, or a workforce that is exposed, not given the expertise, but more importantly, the supplies, the system requirements for them to deliver. So how can we train the workforce when we see ratios of 1 oncologist per 200 cancer patients in Europe, and compare that with 1 oncologist to 5,000 cancer patients in Africa? That is totally unacceptable. So we have to start investing in the fundamentals. And for many years, we've accepted that governments, external partners won't want to invest in workforce. Can we still tolerate that in the era of COVID-19? Second, let us continue, and UICC has shown us so well, how can we improve our messaging? But it's important for us to understand we cannot continue to make endless requests to governments to do this, do that, invest in this new technology. We also have to be able to make priorities and honest concessions. Are there programs that we can say should be de-implemented? There is an easy one, thyroid cancer screening. We know that that should not be implemented in effectively all countries around the world. But what else could there be? Let's try to be honest with each other. Is it appropriate for a low-income country to do a breast cancer screening program in light of COVID when they have 1 pathologist for the entire country? What is the best way for us to prioritize programs that is honest and cognizant of the reality of the health systems in which we work? Question, do we have to sacrifice innovation for equity? We know that innovation has brought great progress for us in the cancer community. How can we continue to orient that towards equity? Innovation must continue. We have so far to go for cancer patients around the world, but how do we start thinking about equity in the lens of innovation? And I think we're learning a lot in COVID to see the very positive response from the private sector to come around this issue of access. A third point, how can we continue to orient our work around patients? And again, the advocacy community has done this so well with UICC. This should always be about patients, but we know this is even more true in the setting of the COVID-19 pandemic. We're seeing sacrifices that families, providers on the front line, NGOs, industry partners, and international organizations are making. But how can we increase the solidarity? because while the cancer community is strong, we also have to think about solidarity. As Princess Dina said, we compete within disease groups, but we also compete even within cancer and within our own spheres. How can we come together in a meaningful way and align our agendas so that we really don't present this disjointed message and a disjointed vision? So finally, just a couple of comments that can share with the audience. What is WHO doing to support countries in cancer and looking at the landscape of strategic investments in the current pandemic? First, we are and have already developed guidance on how to maintain essential services, including those for cancer during the pandemic. Second, we're organizing communities of practice where ministries of health can exchange best evidence and what their country responses are. Third, we're augmenting a tool that we have that allows governments to understand what is value for money within their context, what programs should be prioritized. And this tool now has a specific module for the COVID-19 pandemic that we've populated with evidence-based strategies for how countries can respond given the data that exists. So in that regard, we can come together as a community, and we appreciate the support and this opportunity to do so through platforms that the Chatham House is now offering us. Let us continue to orient around evidence, solidarity, and best practice. We thank you again for this opportunity, and we look forward to the discussion with the group.
Great, thank you very much indeed, Andrea, and particularly like your forward-looking, positive way of sort of dealing with this. I mean, obviously the world is facing this unbelievable crisis at the moment, and that, you know, there is this tendency to throw your hands in the air and say, you know, just despair. But, you know, one can look at this as an opportunity, and you say things must change. And I think, you know, this is what we need to be doing in global health, and the cancer community needs to be doing as well. And you're right, having these discussions with ministries of finance and heads of state to say, you know, this is an opportunity to change things. And so I'm very keen that in our next sort of 25 minutes or so, you know, to have the discussion very much sort of forward looking about, you know, how can we change things? How can we make things better? And encourage questions along those lines. You know, what would they like to see changing and be made better? And I perhaps, you know, ask one or two people to ask their questions on air. And I've noted that one of our dear friends, one great campaigner for cancer services, Mark Lodge, has asked an excellent question, I think, along these lines about, you know, sort of how can we learn, how can we do things differently? So, Mark, would you like to ask your question, maybe of all panelists, but over to you, Mark.
Yes, thank you. And very glad to see Princess Dina, Andre, and Philippe on this call. This is very, very good. I don't have the question in front of me, but it was basically this, that we're all hoping for a vaccine, the development and a safe delivery of a vaccine for COVID-19. Now, we've been here before. What lessons can cancer give to the COVID-19 community specialists? I'm thinking particularly of the HPV vaccine. What lessons have we learned through the delivery and making and providing access to it? Because I think they'll be following the same path. Thank you.
Great, thank you. And I remember we had a conversation at sort of Chatham House round table where we were discussing the success of the HPV vaccine. So people are looking for success stories. So who would like to take that one on first? You know, that what can the COVID-19 researchers and community learn from the HPV successes? Princess Dina, would you like to unmute? Sorry.
Yes, I think that's a really good question by Mark. And we all know that, you know, with the elimination of cervical cancer, the HPV vaccine has succeeded and not succeeded in some ways. Number one, there was the issue of the supplies. There were countries who started taking on the vaccine and they were ready to do it, but then the supplies ran out. So there's that issue they should look into. There were the social and stigma issues about taking the vaccine. So you have to kind of prepare people because, you know, if you have the vaccine and people refuse to take it for worry of side effects, not enough testing time and so on, this is the kind of thing that governments and health authorities need to be preparing for those scenarios. Again, accessibility, very much the logistical issues of actually how you also, you know, it's great to have the vaccine once it comes, but how do you disseminate it? How do you disseminate it equitably as well? We've already been hearing, unfortunately, about high-income countries potentially, you know, coming and potentially when the vaccine comes up, that maybe they will buy up all the supplies and leave perhaps low middle income countries behind and so on. These are the kind of issues I would love the powers to be looking into and understanding the successes and also the weaknesses of when the HPV vaccine was rolled out.
Yeah, if I can jump in, Rob, and build on Princess Dina's point, I think that the key here is that we have to work together. There has to be a dialogue, and there has to be an open discussion between industry, governments, and international institutions like the WHO and others that are involved now in the fight against the pandemic. And you know, there has to be a sense of partnership here and collaboration between those different stakeholders if we're going to find solutions that are equitable and that are going to allow for broad access and distribution for the COVID-19 vaccines when they become available. And so that's a lesson that we've learned from our work in HPV. And I think the point that Princess Dina was making about the challenges of supplying sufficient number of vaccines to meet the demand around the world is a really important one. And you know, we've faced this challenge with the HPV vaccine, and companies like MSD that are producing the vaccine are, you know, have been investing more into manufacturing capabilities in order to increase the volume of vaccine available for HPV. And now, of course, we need to do the same thing for COVID-19. We need to, not only MSD, but of course, all the other companies that are investing into COVID-19 research also need to invest into manufacturing so that we can produce enough of the COVID-19 vaccine to supply the global demand. But you can imagine it's a huge challenge for industry, but also something that we have to tackle together, right? It's not just industry. We have to work together with governments and with institutions to find the right solutions that'll be equitable.
Great, thank you. Now, I'd like to bring in Catherine now, if I may, who I think has got a question for us about palliative care. We've mentioned the importance of palliative care, and Dr. Tedros famously said that you can't have universal health coverage without palliative care. But we've seen, you know, in the UK, you know, the palliative care has been relatively neglected and you know, at great cost. So Catherine, would you like to ask your question of the panel, please?
Yeah, thank you so much for mentioning it. Several speakers have. And we know that now it's part of the spectrum of universal health coverage in the documents, but what's really the challenge is to integrate it in practice into the spectrum rather than have it outsourced to the charitable or faith-based communities, which it is in most countries where it can't possibly meet the need. So my question was basically to Andre about whether or not it's being included in the communities of practice that he mentioned are being organized. And thanks again, this is a super webinar. Out.
Thanks, Catherine. I'll go ahead. Thanks, Rob. So it is, in fact, it will be a cross-cutting communities of practice that will address different needs of ministries of health, and palliative care is one of great interest for the organization. The group working on palliative care is talking about some additional products to help address that issue of how do you maintain palliative care during the COVID-19 pandemic. For us, and I want to also acknowledge the comment, I think, from Stella, which talks about not only pain management, which I know, Catherine, you and IHPC are very sensitive to, but to talk about comprehensive palliative care. In that regard, there are certain things that within the cancer community and beyond, we've been notified that are incredibly concerning. An example is cancer patients, end-of-life cancer patients that are in an intensive care unit and unable to see their family. And this for us is really an issue for how can we structure the response to the pandemic to be cognizant of people who are suffering. Because of course there is a concern, and we understand the liabilities of having people exposed to loved ones with COVID who are in the intensive care and with metastatic cancer. But at the same time, how can we structure the services so we're not just talking about the medicines, but the overall comprehensive services that are required for palliative care? So there is an important discussion on that, and I'm happy to have a follow-up discussion with you offline on how we can link you into that and see what opportunities may emerge.
Great, thank you very much indeed, Andre. And I'd perhaps now like to go to, I think it's Hafiz. We've been sort of talking about difficult decisions, controversial areas, prioritization. So I'm not sure if Hafiz would be able to sort of come on to ask the question. I think you were asking it of Princess Dina, but maybe of the whole panel. So Hafiz, over to you.
Oh.
Hi, good afternoon. Thanks for taking the time. Would love to hear, given all the necessary bodies are here, how can the industry do more so that we don't actually have to ration for our patients?
Yes. Shall I start, Rob?
Yes, please. Yes.
That's a really amazing question. And I think, Philippe, you mentioned earlier about your role, for example, in the City Cancer Challenge. There are so many ways, these are unprecedented times and it requires unprecedented solutions. And I think one of the best examples that I've seen about the pharma industry in supporting the cancer community through the City Cancer Challenge model, where they actually, maybe more than 24 pharma industry actually united under one anonymous name, meaning without their commercial names, called Access Initiative, whereby they all joined together to support cities on the ground with their national cancer control plans and priorities. So this is an amazing model that should work on many kinds of solutions now, especially now with the cancer services being threatened. This could be expanded by for example, by the pharma industry to support this. And maybe perhaps, they can go even further to perhaps suggest with governments and other international bodies that maybe for these unprecedented times to also maybe perhaps create a fund like you have in the UK, for cancer drugs and so on, so that in pockets or areas or low middle income countries where there have become, medical rationing has really become the norm and maybe may continue to be so. Perhaps that could also be something like a crisis fund for cancer community to help us through this period. That could be a thing as well. And also, for example, I know Yahya, a friend of mine, who posted a question as well about cancer research. We cannot let cancer research be stopped or even reduced. We cannot have that. Perhaps that a crisis fund like that could also maintain urgent research that we need. So there are many ways that the pharma community can actually do good in the same way as they are doing, in dosage research and other ways. And I know they've done great work with the City Cancer Challenge model. That will be really great. And also they can support more sort of effective NGOs around the world to continue their important work. So there are many ways that they can do that. I know when you all put your heads together, 24 pharma giants together, you've done wonders. So that's one. But I also wanted, if I may, just to add on what Andre said and the others, is, finding the money and the resources is also, as Andre said, is actually by reducing inefficiencies and losses. That's how you can also release money. Many of our problems in the NGO world is actually the infrastructure of the donor sort of system. Many of us, like Andre said, we compete, sort of joining together. The system doesn't encourage us all to join together. The donor infrastructure is such that way. And that needs to change. That needs to have a reimagined way of it working, so that we actually don't waste resources doing the same thing. So that's also one way. Again, finding money, we go back to fundamentals, as Andre said. Governments, we have all this, if you do cancer control plans, you won't be dealing with, like you said, you might not be working on thyroid screening if it is on the bottom of the list of your priorities. You would actually be focusing all your attention on your disease burden in that country. So that's one. Cancer control plans, NCD plans. Taxation on harmful products. This is where you can find the money. Countries who have done that, like the Philippines, they've done a thing called the cancer tax on tobacco, where they funded their own universal health system because of this so-called cancer tax on tobacco, cancer services, and so on. Again, going back to fundamentals, we've been saying it all along. We've proven that health is an investment. We've proven all the ways that you can unleash resources, but the governments have to start doing it. And I'm very pleased to see, for example, Boris Johnson in the UK has started the fight against obesity, for example, because we all know that how much obesity has and all its effects drains the health systems everywhere for all NCDs and so on and so forth. So honestly speaking, going back to fundamentals, to release money, to reduce inefficiencies, and to have more concerted solidarity that is smart, that is reimagined, so that we can deal with this unprecedented crisis.
Great, thank you. And Philippe.
Yeah, thanks, Rob. One of the reasons why companies like MSD have enthusiastically joined and added their support to the City Cancer Challenge is because we're absolutely convinced that the best way to have the maximum impact on cancer and to support cancer patients in LMICs is really to invest in building basic infrastructure and basic health services in those countries. And so we at MSD, we've made a multi-year commitment, as have other companies, to this effort, right? This isn't something that's going to be solved in 1 year or 2 years. We need a longer term commitment and longer term investments in order to be able to build up those capabilities. And another inspiration for me is the work that Andre has done at the WHO, where his research and his work is also pointing the way to how we can have a maximum impact in LMICs, how we can identify and select the right investments to make the greatest difference for cancer patients. And so those are the kinds of initiatives that MSD is wholeheartedly supporting. And we embrace this approach to the cancer fight in LMICs.
Great, thank you. Andre, have you got some thoughts on this issue, this tricky issue?
Just really, my co-panelists have said everything perfectly. The only minor addition to make, which just reinforces what they've said, is about better communication. Because I think your point, Hafiz, is important about how can we identify bottlenecks in treatment. But we now are building mechanisms for people on the ground to report to us. So report to NGOs, report to WHO, report to industry. Because if you're having an issue with a stock out or a shortage, you shouldn't be alone. And there is a response with CCAN, with WHO, with industry support, in which there is better communication. And this we're seeing, in fact, in COVID. We've been looking at the landscape to see how many cancer medicine shortages have there been because of COVID. And there has only been one notification of that cancer medicine shortage. So if there are some, and this of course is a reflection of a strong dialogue with industry, strong dialogue at the country, we know that there are more, but please know and feel empowered to communicate with your local stakeholders, with your NGOs, with your government, and with your WHO country office. We should use that voice, because when we use that voice, we can start documenting and create a response. But we can't have a response if it's everyone's struggling and not giving specificity to where are the problems. So let's work together to develop that narrative, figure out what are the immediate issues that need to be addressed, and to formulate a response together.
And if I may add, sorry, I need to jump in, and that's actually what UICC has done. We've been doing surveys about disruption of services. There is a recent survey that came out about the financial impact on our community. And exactly that, we've joined the COVID-19 and Cancer Task Force to actually really get very qualitative data on the whole COVID-19 and cancer to assist policymakers. So that side of things, data, giving voice to the community and so on. We've been actually with WHO and others, we've been leading on that because we need to keep our voices heard and our needs very well articulated.
Thank you. And you mentioned sort of the issues around disruption of services. And I think that Pauline Otti has got a question for us about this concern about the deprioritization of cancer services and how we might remedy that. So Pauline, can you ask your question of the panel, please? I'd just like to unmute Pauline.
Trying to see. Okay. In the UK, among other countries, cancer care was downgraded to the bottom in favor of COVID pandemic management. We now know that COVID will be with us for a long time. Can the panel suggest ways to urge governments to reprioritize cancer challenge towards more positive patient outcomes on a continuum of holistic health care and health security, involving all key actors and stakeholders? Thank you very much, Your Highness, and the other panel members. Bye.
So, panel, how were you going to encourage a reprioritization of cancer services?
Shall I?
Yeah, please.
Yeah. I think Andre and the others would agree. We need to, like Andre said, we have to be honest with ourselves. We've been a long time talking about, for example, health worker shortages. And we've seen now so much the need for health community workers that we need to unleash that potential more and more, and we have to have them trained and so on. And it's not difficult, that's the thing. It's not a rocket science, especially now that we've uncovered the power of digital connections like we are doing now. Without having to travel, you can train, you can do all kinds of things to train people and build capacity and so on. So that's one. I think empowering the health community, the community workers in countries, because we've seen that needs to be addressed. Dealing with the shortage of health workers. So that's another one where we can start to see systems being able to deal with such unprecedented demand for health services and so on. Going back to basics, like I said, the only way it can come back is to de-stress the health systems with the lack of resources that it is facing. Taxation on harmful products, that's going to unleash a whole amount of financial resources that could be geared to strengthen the health system again and so forth. Political will, again, we go back to political will. Political will is crucial. If, when they want to find money and they want to do something, they will do it. Demanding our rights as a cancer community. And who is the cancer community? It's us, it's all of us. We're not some people coming from Mars or from another planet. It is us, all of us, our children, our friends, our daughters, and so on. So it is doable, but again, going back to basics, planning, making sure that cancer is part and parcel of the COVID-19 plans. And I know WHO did great work on that with giving practical guidance to government on how they can do that. Maybe Andre, you could add on.
Well, thanks, Princess Dina. Difficult to add on after those comments, but just to reinforce the concept of a narrative, because We know that cancer services are being disrupted. We just finished a systematic review looking at the ways in which cancer services are being disrupted. There are over 100. So it could be workforce related, it could be supply chain related. There are countless. But for us, we have to come back with not just what is the problem, but what is the solution. And this is where we did a similar systematic review looking at evidence-based solutions for mitigation strategies, and we only found 9. So we are struggling as a community to say, here is how you respond. Because governments know, we also have to be honest with ourselves. One day we go and say, your cancer services are failing. The next day, the people from cardiovascular disease will say, your CVD services are failing. Dialysis, you're failing. So what is it that we're asking them to do? And for us to be able to inform that with an evidence-based set of priorities is what the task is. And that's not easy because we give countries priorities like, you should detect cancer early. They say, okay, you know what? I'm gonna screen for breast cancer. And then we find that 50% of low-income countries are screening for breast cancer, and they don't have enough pathologists to manage 1/10 of their overall cancer cases, let alone the cases for which they're screening. So how can we create priorities that are appropriate for the context, for which we can generate some investment or investment case or a business plan, and then advise governments to say, this is the full narrative. Here we're helping you understand the problem. Here's a solution that you should consider, and here's the justification, as Princess Dina said, and here's how we can mobilize other partners to be part of that. Ministries of Finance, development agencies, NGOs, industry, all come together and say, we understand, this is the package that we're investing in. And sometimes in cancer, we only go halfway. So really the plea for us is to go further and say, yes, services have been disrupted, but for us, which ones are the most problematic? What are we going to do about it? And how are the different stakeholders going to contribute? So with that, we feel we can do more. We see the UK is having those types of discussions, and they're moving forward. There are countries that are further behind. There are some countries that are ahead. What can we learn from each other? How can we create a better narrative? And then use that as our platform to convince people to invest in change, not just understand that change is necessary.
Can I just sort of follow up on that, Andre? And it's a question that's been asked, where are the good examples? You mentioned briefly that UK there, and Princess Dina mentioned sort of Philippines, the work that they're doing, but looking for the good examples that we can share. And of course, WHO has this role in information sharing. Are there shining examples that we should be looking at the moment?
Yeah, so COVID, as it pertains to COVID, Rob, or broadly for?
Yeah, I think, countries that are perhaps, reacting well to sort of COVID-19, that aren't really disrupting cancer services, and maybe even, sort of doing some radical, exciting things. Actually, our next webinar, just to encourage the audience to join in 2 weeks' time, we'll be looking at this topic of innovation. But as a little taster, are there any good examples at the moment?
All the countries that have women leaders.
Excellent.
All the countries that have had women leaders. Full stop. Say no more.
I'll have to withdraw any further comment. That was the one made by Princess.
Well, thank you very much indeed. And I think that is a very good point to finish on, because what you're alluding to there as well, Princess Dina, is political leadership. That you can have all the information, you can even have all the resources, but some countries are clearly doing better at tackling the pandemic than others, and a lot of it is coming down to political leadership. Without mentioning any specific political leaders, we can see some are making a real mess of it. I think this is a crucial aspect, and one thing that we're very keen to do at Chatham House is to bring the global health community together to articulate the case better to political leaders. And I think this is the challenge. When we had our round table about a year ago, we were discussing, there was great agreement around the table, a real high degree of consensus, but what we recognize that we need is public financing, and the way to get that is political commitment. And I think this is going to be the big challenge for all of us. And this is a recurring theme through these round tables and these webinars, the importance that we articulate the case better to heads of state, and will be something we'll be discussing in a fortnight's time. But we've hit the hour mark now, and I've been delighted with the turnout. It's very rare for these webinars. The actual number of participants I've seen has been steadily going up through the course of the last hour, which I think is testament to your wonderful answers and interventions. So thank you very much indeed for joining us today, and our audience for being brave enough to come on air to ask questions. I think it's much nicer that we can do that, and very much encourage you to join us in a fortnight's time and get your friends and colleagues to register as well, where we'll be discussing innovation and the opportunity to improve cancer services coming out of this crisis. But for today, thank you very much indeed, and please stay well and safe wherever you are. Thank you very much indeed. Thank you.
Thank you very much.
Thank you.